Good morning. I'm Hervey Kimball. Today's topic is hand and wrist injuries in athletes. I'm one of the hand surgeons here at New England Baptist Hospital. So this topic is broad and does involve a lot of different components. So this is the first part. We'll go through a little bit of the outline for today's talk in a minute, but for the most part, hand and wrist injuries occur in about 3 to 9% of athletes. They're more common in the adolescent athlete, and for those that are involved in ball handling sports, we typically see finger injuries, but for those that are in contact sports, typically we'll see injuries to the wrists and the metacarpal. We can divide the athletic injuries into those that are acute. Those would be typically fractures or dislocations, ligament or tendon injuries, or even injuries to the cartilage of joints. And then we can divide it also into those that are considered stress-related or overuse. When we look at how wrist motion is needed for certain activities, this graph here demonstrates the activities of daily living in the sky blue color as wrist extension and flexion along with radial deviation. Again, those motions would be flexion and extension, radial and ulnar deviation. You see arcs of motion between 30 and 40 degrees to less for the side-to-side motion. But when you do specific sport activities such as pitching, you need extra flexion to put some spin on the ball. And also for free throws in basketball, that's useful. As we look at the things that we'll talk about today, at first we'll discuss tendon injuries. We'll start from the fingers and go proximally to the wrist. We'll look at common fractures. And then in our later talk, we'll discuss carpal instability, which is a very common problem, and also cartilage injuries to the wrist. So firstly, as we look at the very end of the finger, we can commonly see an injury called a mallet finger. That's where a tendon is injured, the extensor tendon that helps straighten out the tip of the finger, typically from being jammed. A basketball is a typical traumatic injury where the ball would hit the tip of the finger and cause the tendon to rupture at the very end of the finger joint. If the patient has significant looseness to their joints or ligamentous laxity, we would see compensatory deformities of the finger, referred to as a swan neck deformity. And when we look closer at these type of injuries, we can, it's important to get an x-ray to see if there's been any bony injury or fracture. So typical treatment for this injury is about 8 weeks of splinting with the finger in full extension. That's just a splint for the end part of the finger. So the other part of the finger, the PIP joint, is allowed to continue to move free. When we look at this image here, this is a radiograph showing a mallet injury that has an associated fracture demonstrated at the arrow point. Now, in this case, two things are important to understand. Firstly, that the fracture itself involves a larger portion of the cartilage surface for the joint itself. And then secondly, the bone appears to be subluxed or is shifted out of position from its normal overall alignment for the finger. So those are two things that are important for us to consider and would be typically something that we would consider doing surgery for. So again, this is you see here on this slide the indications for surgery, but also a compensatory swan neck deformity of the finger for someone that has a mallet injury. In this case, in the other previous case, the pinning is performed to keep the finger out straight and realign it and allow for healing of the tendon or the fracture. So moving on to the next significant injury that can affect athletes would be considered the jersey finger. Now again, this is a tendon injury affecting the finger, and it's most commonly in the ring finger. This involves a flexor tendon injury. Typically, as you see in the picture of the rugby player grabbing a jersey, with that forceful grabbing, the ring finger itself seems to become a longer finger in that grasp type activity. And as the jersey is grabbed, it causes an extension force along with the player pulling down onto the finger, causes an eccentric load or ultimately a tendon rupture. So initial treatment for this is recognition of the problem and splinting them in a functional position. Typically a functional position is a position like this where a splint is applied to the back of the hand. This image here, along with the MRI view, shows what we would expect to see in a player who's had this type of an injury. The ring finger is unable to flex because the flexor tendon has been torn from its attachment. And on the MRI, you'll see at the lower red arrow, that's about where the tendon is retracted to. So it's pulled down to a position towards the PIP joint, or just proximal to the PIP joint of that ring finger. Normally, it should be inserted out here at the tip. This is Leddy and Packer's classification of this type of an injury. The importance of this classification involves the ability for us to appropriately treat this. So for the type 1 injuries, those are the more significant injuries. They involve the tendon retracting all the way into the palm level. Now when that happens, the blood supply gets disrupted for the tendon, and the tendon tunnel, which is called a fibroosseous sheath, that tunnel collapses over time. Once that collapse happens, it's very difficult to surgically repair that tendon back out. So those patients have about a week to 2 week window where we need to address this surgically. For the other types, types 2 and types 3, the fibroosseous sheath stays intact, and for the most part, and it's easier to repair those. We can repair those up to usually about 6 weeks or so. Sometimes if it's really just at the very end, those can be repaired months later. When we talk about doing the repair, this slide just demonstrates a little bit of how the surgical technique is performed. On your right, you'll see the tendon itself with some sutures in it, and then on the left, you'll see how a needle with an eye is passed through the bone, and then it allows us to pull the suture ends through the bone and ultimately to tie them over the top of the nail. When they do have this type of a repair, it's important to protect that and allow it to heal, and that usually involves rehabilitation with hand therapy for 6 weeks of very protected motion, and then after that, gradual return for strengthening. Another very common injury is finger dislocations. Even if you don't play sports, you're at risk for having this type of an injury. Usually, we see sprains occurring to the PIP joint of the finger from a hyperextension type injury. And in those cases, we usually see a volar plate injury. We'll look at the volar plate and its anatomy in a minute or two. And those injuries that are dislocations that occur volarly, much less common, but those can be seen with having a central slip or extensor tendon injury, which would give you a boutonniere type deformity, and we'd see limited ability to straighten out your finger immediately after that injury occurred. But we'll look at those in a minute. So this is a slide, anatomy slide of the ligaments that are around the PIP joint and the MP joint of the thumb. So the important thing from this is to understand how the ligaments work on each side of the finger joint, and then how we are testing these ligaments. The more important proper collateral ligament is not really tested with the finger straight, that you're really testing the accessory collateral ligaments. And you can see when the finger is straight, those ligaments appear tight on that image. When we flex the finger down to about 30 degrees or so, that's when we're really going to be stressing the main collateral ligaments. And that's where we want to assess, has there been a significant ligament injury? This slide here shows the more common PIP joint dislocation that involves the volar plate avulsion. Now this tissue is very stout tissue at the base of the joint, and that prevents our fingers from overextending. When you do overextend them and ultimately dislocate the finger, that gets torn from typically the base of the proximal phalanx. Now that ligament can have some bone attached to it, or the volar plate can have some bone attached to it, and that's important for us to recognize and ultimately may determine how we treat these type of an injury. As I mentioned, it is a very common injury for the PIP dorsal dislocation. We may see patients that have that type of an injury and spontaneously have the fingers slide back into position. Other times they may have their friend or co-athlete reduce it, or trainer reduce it on the field, or occasionally they'll go to the emergency room to have it reduced. We'll typically see stiffness and swelling affecting the joint for a number of months while that healing process happens. But it's important for clinicians to assess after reduction is performed for instability and ultimately their range of motion. This helps us assess what's been injured and is there a significant problem that may need surgery. Typically, the PIP joint dislocation that occurs during a basketball game or a soccer game, we tape them up, and depending on if they're a professional athlete, we let them go play that same day. But it does require some initial splinting and buddy taping. The idea for that is we really want to allow for protected motion. We found that for recovery, early motion is better than a long time of splinting. If they're put in a splint, typically we'd see a popsicle type splint, and patient may be put in that for a couple of weeks. They'll really come to see us and they'll have some significant stiffness. So we really like to get them moving pretty quickly. But that has to be within the normal ranges of the motion for the joint. If you're overextending the joint, then you're not allowing that tissue to heal back down. So we have to have some protection, and the buddy taping typically provides that. And that protection we really need to typically have for a 6 to 12 week period. So for certain cases where we see fractures that are larger, similar to what we were just looking at with the mallet injury, if the fracture is more than about 30% of the joint, we're a little concerned about that and may ultimately need to consider surgery for that. Also for those joints that are unstable or we can't seem to reduce them, then those are ones we're going to think about doing surgery for. We occasionally see the type of fracture that doesn't necessarily need surgery but needs some other type of treatment. And in cases with this avulsion type fracture, just bringing the finger down into a bent position realigns the fracture fragments, and you can see that on this radiograph here with the finger bent down. Now over time we would gradually allow the finger to slowly extend over a period of about 4 weeks. We don't like to keep the finger in one position for a long period of time because it will get quite stiff, so we're concerned about that. Now this is a different type of a fracture, same location, but this one is, the red arrow shows some impaction of the articular surface. And when we reduce them down into a bent position, you can see that the articular surface there is not reduced. So this type of an injury needs some other type of treatment, and typically that involves putting some pins in to create an external fixator that will allow for protected motion of the joint. And in this case, we've had the patient undergo a little incision with a device, either a little bone tamp to realign that articular surface. Once that's been done, the joint is again congruous, and this particular apparatus allows us to maintain motion so they don't get too stiff. Now the other type of PIP joint dislocation is the uncommon type, which is volar dislocation. When we talk about dislocations, we always talk about where does the distal end of the limb go. So for volar dislocations, this part of the finger is going to go volar. The more common is for this part, the distal end, to go dorsal. So with this particular volar dislocation, you can see on this image here where you injure the extensor tendon. Not the volar plate like the dorsal dislocation, but with the volar one, you're going to injure the extensor tendon. And that's going to leave you with a deformity that's known as a boutonniere deformity. And they have trouble extending their finger because the extensor is no longer working. And that's what we want to look for in these uncommon injuries. Unlike the dorsal dislocation, which are typically very easy to reduce, this particular injury may not be reducible. So there is a technique to reduce this type of a dislocation. We want to take all of the stress off of the tendons that are holding the bone out of position. And by doing that, we extend the wrist, we flex down the MP joints, and then we try to extend the PIP joint by pushing the head of the phalanx between those two tendons. Now for the volar dislocations that are reduced, we instead splint these for quite some time. Unlike the other dorsal dislocations, these require a splint in extension for 8 weeks. We found that if we don't wind up doing that, they get a gradual flexion deformity and recurrence of that boutonniere problem. It's important for us to realign the extensor mechanism when we're splinting these patients, so it's really just a splint that involves extension for the PIP joint. We want to have the DIP free so you can work on that motion for the end of the finger. Now when we talk about the dislocation that's irreducible, we do require surgery for that in order to put it back into place. And ultimately, this slide describes a little bit of the technique to do that. But in essence, when we do reduce it, we are going to repair the tendon that's been torn on the dorsal aspect of the PIP joint. And again, once that's been done, we're going to splint them again for 8 weeks. So now we'll move on to some finger fractures, typical fractures that we would see. It's very common to have these with contact sports, as I mentioned earlier. Most of these type of fractures are stable. They can be treated with a cast or a splint. Typically with casting of hand fractures, it's important to realize that the fingers tend to get very stiff, as I've alluded to previously. And with that stiffness, we worry about prolonged immobilization causing more stiffness. So with hand fractures, we're typically casting only for 3 to 4 weeks as opposed to, say, a leg or an arm fracture that would be casted for 6 or 8 weeks. So this shorter time allows us to begin early motion, and typically with that early motion we'd switch from a cast to a splint. When we look at particular fractures of the fingers, we really want to look for functional problems, and that is when you break a phalanx, you might see rotation or shortening. So we always want to check and see how the hand is aligned, the cascade of the fingers, and then also, as shown in this image here, when there is rotation, the fingers will overlap, or you'll see them actually spun around a bit. And in those cases, that would be an indication to consider surgery. Another important factor that affects these type of fractures are the forces of the extensor tendon. This image here shows how the forces of the extensor tendons and the intrinsic muscles affect and ultimately cause a fracture to go out of place. And we might see a fracture of the proximal phalanx that looks non-displaced, but we know that there's a pretty high chance for this to happen because of the normal tension that's in our body, in our muscle tendon apparatus. So again, looking at certain types of fractures, when we consider, is there a rotation, is there significant shortening, is there a malalignment, or is it the type of fracture that's really just going to go out of position like is seen in image A here? That oblique type of a fracture is just going to tend to slide down that plane and go out of position. You can almost guarantee that's not going to be held with a splint. So in those cases, we would do surgery, and that can involve just simply putting pins through the skin to hold it in place, or doing open reduction, internal fixation, ORIF, where we make an incision and put plates and screws or just screws in. Now the idea with that type of fixation is really to provide an internal cast and get early motion. So we only splint them for a short period of time, 2 weeks, and begin early motion for them. These radiographs here show a typical boxer's type fracture, although this, in fact, is more what boxers get. Those that sort of punch walls won't necessarily get this type of a fracture. This is more from a real collision with the fist or the hand appropriately aligned for punching. And you see the breaks occur towards the base of the metacarpals here. This is what we would more typically see and known as a boxer's fracture. This would be a younger patient, typically a college student that punches a wall maybe, or an athlete that's upset with their performance and they punch the locker in the dugout. We've known a few professional athletes to have done that. So when the bone is angled enough, we can tolerate, for the small finger, and this shows a small finger fracture, we can tolerate quite a bit of angulation for that because we have quite a bit of motion, normal motion for our metacarpal. So the angulation for this particular bone of fractures can be up to 40 degrees. Once it's beyond 40 degrees, we think about realigning it and pinning it. So the next image here shows a few different versions of how that can be done, with pins placed either transversely or longitudinally. We'll move on now to thumb injuries. Again, very common here in the Northeast with skiing. Skier's thumb is an injury to the ulnar collateral ligament of the thumb. When we look at the thumb, the MP joint, as we saw earlier, has two ligaments on either side of the joint. And for this ligament here, this is the ulnar side of the MP joint. So this is the ulnar collateral ligament that gets injured as a ski pole begins to hyperabduct the thumb. And with that hyperabduction, you typically get a rupture of the ligament from its insertion on the proximal phalanx. When we see these patients, they typically have a swollen thumb that can be unstable. And when we check for stability in these patients, we want to stress the joint. And normally there is some laxity to the joint. So we say if it's more than 15 degrees from the other side, or if it's more than 30 degrees overall angulation, then we're concerned of a significant ligament injury enough to consider surgery. Now with this type of a ligament injury, there's one variation called a Stenner lesion. And that Stenner lesion involves the over-abduction of the thumb, so much so that the ligament pops out and goes under the abductor mechanism. So this adductor retinaculum winds up getting in place of where the ligament normally would attach back down to the bone. So on clinical examination, we will feel a lump or the end of the ligament. In this case, we know that there's no way that that ligament is going to heal back down, and in essence, this is requires surgery to repair that. For most ligament injuries that involve the thumb, most skiers' thumbs can be treated with a thumb spica cast or a removable splint. Those that require surgery, as I mentioned, if they have really significant instability or this Stenner lesion or displaced fracture. Now this image here shows a circled fracture fragment. Now that normally should be closer to the base of the proximal phalanx. So in this case, we know that the injury or the ligament is significantly displaced and will not heal back in position. This image here shows a little bit of a similar scenario where as soon as we cut through the skin, we see that the ligament is right up under the skin, and that's where you would palpate that Stenner lesion. That ligament ultimately gets repaired back down to the bone. So moving on to other fractures of the hand. At the base of the thumb, another common location to get fractures. This is a commonly source for an axial load type fracture for the thumb. The base of the thumb fracture, the CMC joint, is those type of fractures are typically referred to as a Bennett fracture. That's a common pattern. When orthopedists are tested about this, it involves injury to a fragment that has an attached ligament known as the anterior oblique ligament. When we look at these fractures, if they're truly non-displaced, they can be treated in a cast. but we're cautious for these types because they have a tendency to sort of slip out of position. And that's, again, because of the native forces that are in the muscles and tendons. This slide here shows a little bit of how the forces of the muscle act on the bone to displace it. So we have to sort of reverse those forces when they are displaced in the operating room, and then go ahead and pin the bone into a better position or a reduced position. Occasionally we'll have to actually do an open incision to reduce the joint, but in most cases these can be closed, reduced, and pinned. This would be an example here of this radiograph showing a reduced fracture with the pins across the joint. And treatment for this would involve a cast for a period of about 8 weeks, and then those pins would be removed. So we'll move on to carpal fractures. At the wrist, the bones, the carpal bones of the wrist, common injuries, and probably you all know about scaphoid fractures. They represent 60% of all wrist fracture, carpal bone fractures. And typically you're injured when you have a fall on an outstretched hand or arm, maybe being tackled or falling, playing soccer or whatever sport. We look for, we're very concerned about these type of an injury, so all physicians are trained to look for and be careful about this particular fracture. And what do we look for with the clinical exam is always to check for snuff box tenderness. As we look at our wrists, the two tendons that go to the base of your thumb at your wrist create what we call the snuff box, and in between the two, if you push right in there, that's where you're going to feel the scaphoid bone. And if you have tenderness over that bone, there's concern that it could be broken after that fall. So for those that have fractures, we are concerned mostly because of the blood supply to this bone. The blood supply comes from the distal end of the bone and then travels through the center of the bone to get the more proximal portion of the bone. And with that, if you have a break through any part of the bone, the more proximal part of the bone, or the bone closer to the radius, has limited blood supply. And with that, we are concerned for limited healing, and then ultimately a concern for osteonecrosis of the bone. So when we look at the type of fractures that occur on the more proximal part, or the proximal third of the bone, they can have non-union rates of up to 30 to 70% in the literature. So for these type of fractures, we're very concerned, and oftentimes we'll recommend surgery for them when we first see them. Sometimes we'll consider bone stimulator as a way to, along with casting, to initially treat these. Again, as I alluded to, when we look at these type of fractures, we divide it into thirds. And so for the proximal pole ones, obviously we're concerned. But even for the distal and waist fractures, with waist fractures, we may not see them right away. You may have a suspicion based on tenderness or clinical exam, but the radiographs will be normal. In those cases, we typically would obtain an MRI or get a CAT scan to evaluate the athlete that's had that type of an injury. If we do see a fracture that's in the middle part of the bone, or the middle third, with non-displaced fractures, there's a pretty good rate of 90 to 100% union. But that does take some time, and it does require typically 3 months of casting. Now, the cast for these type of fractures are typically a thumb spica cast that involves immobilizing the thumb and going up to the elbow level. Some surgeons or orthopedists would prefer to have it go across the elbow. So when we do cast these patients, we try to maintain them in a little bit of a wrist flexion and radial deviation to take some stress off of the healing bone. When we've looked at studies allowing athletes to get back to playing in casts, we found that they actually have a higher rate of needing to undergo surgery to fix them, because they go on to non-union a little bit higher rates. So based on this and some other studies looking at the cost effectiveness for care, we found that most would favor ORIF or open reduction internal fixation to treat these, and that typically, even for non-displaced, stable appearing fractures, compression screws or percutaneous screw fixation is typically the norm now. When studies have looked at either screw fixation versus a cast, higher union rates with screw fixation and greater strength at early recoveries, in essence. Again, there's clear evidence for fixing these fractures if they are unstable or significantly displaced. We have to realign the articular surface to avoid traumatic arthritis. So there's no doubt that if we find an athlete with a displaced fracture, we're going to recommend surgery for them. It's not uncommon to see these injuries missed, and maybe the young adult or athlete doesn't seek medical attention for it, and they come to see us 6 or 8 weeks later, or even months later, with some swelling of their wrist, and we can see that they have a non-union or a delayed union. In those cases, we may require bone graft to fix them. So we'll sort of wrap this talk up today, looking at a few of the other carpal fractures that happen, and we can take questions later. I guess lastly, we'll talk about the hamate fracture, which can occur in racket sports or baseball or tennis. It's a common source for undiagnosed wrist pain with most likely a stress fracture that occurs. The image here that you see shows the P as listed as the pisiform, and that's the bone that's in the FCU tendon at your wrist, ulnar side. And a good way to locate where the hook of the hamate is would be to put your thumb, your opposite thumb, IP joint right onto the pisiform, and then flex the tip of your thumb down, and you'll feel the hook of the hamate right there. So for an athlete that's had some ulnar wrist pain that's been going on for a few months, and x-rays seem to be normal, you try a little clinical exam like this, and you may be able to pick up that they have a stress fracture of their hamate. Again, routine radiographs would more than likely be normal, so we do have to do some special imaging for this, and that's typically a CAT scan. Occasionally a carpal tunnel view of x-ray down the carpal tunnel itself may be able to elucidate that. It's much easier seemingly with a CAT scan. In these cases, these type of fractures, for the acute fracture, just simply putting the athlete in a cast for about 4 to 6 weeks, only about 50% of those will heal. So there are certainly times where we go right to surgical excision, which gives them the end result. It's a part of the bone that's not necessary, so we don't need to actually fix that end of the bone. We take it out, and they're able to get back to their sports pretty rapidly. So this will wrap up our first part of wrist and hand injuries. We will talk in part 2 about carpal instability and TFCC tears, carpal instability, including scapholunate ligament tears. Kind of a bigger topic and more to go over with those, so we'll spend quite a little bit more time on those. So thank you very much for your attention, and we'll take questions.